Good morning to everybody. I'm going to share my presentation here. Okay, let's start. First, I would like to thank Dr. Sparriers and the organizing committee for this kind of invitation. I think Dr. Sparriers is the expert of tricuspid transcatheter valve disease in Greek and European territory. So I'm going to start about the anatomy, nomenclature, and etiology of tricuspid valve disease. The tricuspid valve is the largest of the four valves with an orifice area around 7 to 9 square centimeters, and its size changes at about 30% during cardiac cycle. It sits between the right atrium and the right ventricle, preventing backflow during ventricular systole. It can be divided into four components: the leaflet, the papillary muscle, the forehead attachment, and the annulus. The anterior leaflet is the largest and most mobile. The posterior often scalloped, shortest around the ring. The septal leaflet, least mobile, anchored to the septum, slightly lower than mitral insertion. The leaflets meet at commissures with important landmarks near the coronary sinus and aortic root, and the valvular coaptation occurs just below the annulus with 5 to 10 millimeter overlap that allows some stretch without leaking. The papillary muscle and the chordae tendae, the tensor apparatus composed from the papillary muscle and the chordae tendineae. The papillary muscle will have the anterior, which is the largest, supports the anterior and posterior leaflet. The posterior, that supports the posterior septal leaflet, and the septal papillary muscle, which is variable. The chordae tendineae are fibrous cords that tether valve and leaflets to muscle or walls, while the septal chordae inserts directly into the septum or with multiple small papillary muscles. These phenotypes can interfere with interventional procedures. The annulus is non-fibrous muscle structure with D-shaped, two segments, C-shaped, and the free wall of right atrium and right ventricle and straight septal segments, contains muscular bands, minimus fibrous tissues. It's dynamic, its size changes about 30%, as already spoken, can dilate in secondary TR. Important to know that the tricuspid annulus is not a robust fibrous ring. It's incomplete, especially in the segment corresponding to the right ventricle free wall. The annulus here, you can see an illustration about the anatomy, the normal, in the upper image, the normal tricuspid annulus in the short axis left and profile right view shows a saddle shape with two high points, anteroseptal and posterolateral, the yellow cycles, and two low points, the posteroseptal and anteroseptal, the blue cycles. The anteroposterior distance, the red line, is longer than the septolateral distance, the black line. Below, you can see a patient with functional regurgitation with a dilated annulus, which is now circular, more planar, with decreased high-low distance and increased septolateral diameter, the black line. So, in fractional regurgitation, the annulus becomes more planar and dilated in the anteroposterior diameter. Some important adjacent structures, the non-coronary sinus of Valsalva, risk of aortic perforation from transcatheter devices, the AV node and the bundle of His, risk of heart block. The heart rate coronary can be used to locate the location of the annulus, and superior and inferior vena cava serve as landing spots for devices during transcatheter heart procedures. Here you can see the coloration of tricuspid valve and the right coronary artery, the left coronary artery, the mitral valve, and the aortic annulus. The right coronary artery runs within the tissues of the anteroventricular junction, variable levels relative to the level of the leaflet annulus. Here we're going to talk about the Koch triangle. The septal part here of the tricuspid annulus marks the anterior border of the triangle of Koch, which is the anatomical landmark for the location of the anteroventricular node sitting at its apex right here. The posterior border of the triangle is marked by the tendon of Todaro, while the inferior border is the orifice of the coronary sinus. Here is an illustration of the correlation between the main tricuspid adjacent structure and the aortic valve. As you can see here, you can see the right coronary artery, the aortic valve, the arterioventricular node, and the coronary sinus. A classical slide about the tricuspid valve nomenclature classification and the incident of tricuspid morphologies. We talk about tricuspid valve, but mostly 54% it's a 3-leaflet configuration, but we also have 2-leaflet configuration, 4-leaflet configuration, and 5-leaflet configuration in different types. We use a lot of imaging modalities to assess and diagnose the tricuspid valve disease. Here you can see some imaging modalities. We can see the utility of CT and MRI tricuspid valve intervention. Maybe sometimes the solution is only a 3D transthoracic echo, which provides an accurate assessment of the valve's anatomy from both ventricular and atrial perspectives. Finally, the fluoroscopy and moreover echofluorofusion can provide further information about the tricuspid valve anatomy during transcatheter intervention. In the second part of my presentation, we are going to talk about the etiology of tricuspid valve disease. The tricuspid valve disease includes a wide range of congenital and acquired causes and can manifest itself as tricuspid regurgitation, stenosis, or a combination. Usually results in and from systemic disease through hemodynamics, and early detection and treatment improves survival and quality of life. Primary tricuspid valve disease, less common, only 10%. It's about structural abnormality of the heart and can be categorized further into congenital, acquired, and usually manifest as tricuspid regurgitation. So here you can see some examples: congenital Epstein anomaly, tricuspid atresia, cleft valve, malformed valve with stenosis, infection, endocarditis with vegetations and leaflet distraction, inflammatory such as rheumatic disease with fibrosis, infiltrative carcinoid amyloidosis tumor with fibrosis, degenerative myxomatous degeneration with prolapse and organ rupture, and finally iatrogenic or traumatic from pacemaker, biopsy, or trauma. Here you can see some interesting image videos from different causes of primary tricuspid regurgitation. Here is a slide about the well-known carpet gate classification of leaflet mobility, about type 1, the normal leaflet motion, type 2, excess leaflet motion, type 3, restricted leaflet motion, and the classification of the different causes of the primary organic TR. Let's move on to the secondary tricuspid disease. More than 90% of tricuspid regurgitation secondary functional is a consequence of loading condition, right chamber remodeling, results from major or ventricular pathology, needs many modalities to diagnose, and can be categorized further into lead-induced, left heart related, precapillary pulmonary hypertension related, right ventricular disease related, and atrial tricuspid regurgitation. Here you can see the key points about the difference between mechanism of the atrioventricular and device related secondary TR. We can see atrial secondary TR that the annulus is significantly dilated and the leaflets are normal, while in ventricular secondary TR, the annulus is mildly dilated and the leaflets significant tethering. Here you can see sum up a table about the main differences about the leaflet tethering, the leaflet restriction, the right atrium and the tricuspid annulus dilatation, the right ventricular dilatation, and the right ventricular dysfunction, and the Carpentier and again classification of leaflet mobility in the secondary functional manner. About the type 1 is atrial and the type 3B is mostly ventricular. It's the no more forgotten valve, as already said. Survival is significantly worse in patients with moderate and severe tricuspid regurgitation, especially patients with chronic heart failure. Although it's only 0.4% treated, and we have a lot of options, transcatheter options for intervention according to differences in anatomy and physiology. And we can see here some pros and cons of transcatheter tricuspid valve replacement. We decrease regurgitation, procedural complexity, but we increase sustained results, but we also increase screening failure, AV blocks, RV failure, and vascular complication. And at this point, I would like to thank you.
Great, on time, and very informative lecture, Dr. Kosmas. We cannot overemphasize the importance of anatomy. I was just talking with Dr. Kotoulas, and the only thing I could add is that before you start cardiac surgery, cardiology, if it would be possible to spend 2 months in a place that you learn really anatomy, if we all stop and think, it will be so helpful to know the anatomy in detail. And I think, personally, that it's missing from our training, good anatomy. And I enjoyed your lecture. Any questions, please? Thank you very much. On time, and we're going to proceed to... Please.
Congratulations for your presentation. We have to highlight the different kind of dilatation of the annulus. It's not the same with mitral valve. It's just for the free surface of the the right ventricle. So it is a different dilatation of the annulus. This is a critical point.
A small comment. Thank you for your comments. It's very important that we cardiologists need your experience, your expertise as cardiac surgeons in order to better understand the anatomy and the physiology of the tricuspid valve. It's a very complex valve, as I've already spoken, and I would like to thank you. I hope you enjoyed the presentation.
Okay, so the next colleague is Dr. Krommydas.